So, dear colleagues, dear friends, it is really my privilege and honor to welcome Professor Beverley Hunt here today. And it's more than that, it's a real pleasure, because she combines a number of qualities that make her original and remarkable. First, and this is a bit provocative, she's a hematologist. And we all know that this specialty only brings together exceptional individuals, I try to be one, who understand the very special language and voice of blood. Second, she has an internationally recognized reference expertise in the field of thrombosis and hemostasis, a skill which, once again, can only be applied to individuals who stand out of the crowd. And even though her motherland lives outside the European community, we share a deep interest in certain issues, over and above idiotic political considerations. Third, she is a woman, and a woman with very high medical and university responsibilities, being a professor of thrombosis and hemostasis at King's College London. And this is a human phenotype that is still very much lacking in our hospitals and universities, and I deeply hope that it will change. Fourth, she began at Liverpool Medical School, right, and sang in a band. We thus now have the real identity of the hidden female member of the Beatles group. Fifth, she also did a lot of acting, a hard job, but the practice of university teaching includes an actor's performance, dimension, or theatrical, which reaches its peak during invited conferences and lectures. So it's time to give her the floor, Professor Beverley Hunt.
Thank you. Such a lovely introduction. I hope I can live up to this. Now, I do have a major problem. I don't know what you want. And I wasn't here yesterday because you had a strike in your airport. So I will start talking, and then you can say, no, we know this, and I can move on. So, or if anyone has any questions as I go, please let me know. Okay, so this is my hometown, and I have a lovely office. And if anybody comes to London, I have the office just here, and I can look out and watch the naughty members of Parliament drinking too much wine, hopefully not French wine, over the other side of the River Thames. I know you've done the basics of hemostasis, but I'm going to do it from my hematological viewpoint, just so that you have heard it in different ways. It's the best way of learning, having some repetition from different people. And I think you've done primary hemostasis, which is formation of the platelet plug, and then secondary hemostasis is when coagulation gets involved and we get fibrin deposition. But we also need to remember we have to heal, and that's where fibrinolysis comes in. Goodness, we've heard a lot about platelets so far today. I like platelets when they're circulating, looking like a donut, and they're in active form. But of course, we get these activated shapes. They extend their podia. There's a calcium flux within the platelet, and all sorts of things happen very, very quickly. We do need to remember that they are anucleate, but they're just a big bag of chemicals that can react to all sorts of stimuli. Now, we've heard a lot about von Willebrand factor, and I just wanted to stop and think about it from my perspective. So I deal with von Willebrand's disease. You've got a deficiency of von Willebrand factor, and you have a prolonged bleeding time. You will bleed very easily from mucous membranes. You will bruise very easily. And if a surgeon puts a knife in you, you'll bleed even more. So here is a model of von Willebrand factor. It's secreted from the endothelium, where there are packets of von Willebrand factor. So this up on the left is from the human heart. I did it about 20 years ago when I was actually a surgeon, and it was an explanted heart, and we looked at von Willebrand factor everywhere. At the bottom, we've got electron microscopy, and you can see that the endothelium has got these bags known as Weibel-Palade bodies, and that is where the von Willebrand factor, which is made in the endoplasmic reticulum, ends up. Little packages of von Willebrand factor. And if I was to make you go for a run, so you produced adrenaline, put a knife in you, serotonin, histamine, all of those drugs would stimulate you to have your Weibel-Palade bodies go to the surface of the endothelium and anneal with the surface and release all their von Willebrand factor. So you can get really high levels of von Willebrand factor very quickly. So at the start of an operation, when the surgeon starts, when the anaesthetist starts, you have 200% von Willebrand factor. If you were to go for a run, you'd push up your von Willebrand factor levels too. And on the inner lining of those Weibel-Palade bodies, which have got other things in them as well, are actually molecules called tissue plasminogen activator, which will activate fibrinolysis. So the molecule will go up, it'll anneal with the endothelium, and you also stimulate fibrinolysis. So von Willebrand factor is made like Greek plates, stacks and stacks of them, and the first early von Willebrand factor molecules are very large. There might be 20 in the stack. And there's a molecule that circulates called Atomix 13 that will grab those big molecules and break them down into smaller ones. Now, what makes von Willebrand factor so interesting is that clinging onto its side is factor 8. So if you have von Willebrand's disease, you will have a deficiency of factor 8. And you can see, we call it the ligand for platelet adhesion. That's my language, but it's different from yours, but we're saying the same thing. So it will, through the glycoprotein 1b receptor, bind and then bind to exposed collagen in the subendothelium if we get endothelial damage and the subendothelium exposed. And then it also will work through the 2b3a receptor, but mainly that's the main one for fibrinogen. We were just talking before we went on break and saying that if you have a deficiency of this molecule that breaks down these big molecules, then you have a disease known as thrombotic thrombocytopenic purpura, where you've got thousands of huge molecules of von Willebrand factor floating around. They will spontaneously activate platelets, and you will actually get platelet aggregates blocking all the small vessels, particularly in your head and your heart and your kidneys. So that's thrombotic thrombocytopenic purpura. And it's a big problem dealing with von Willebrand's factor in different situations. So quite often we don't diagnose von Willebrand's deficiency until people are quite old, because it's an autosomal dominant disease. And what are the symptoms? Well, you bruise easily, but then your mum and your sister and your brother might bruise easily, so you'll consider that normal. And the women might have heavy periods, but when they compare their periods with their mother, they will say, well, that's normal. So very difficult at times to diagnose, and sometimes we find patients who are oozing post-operatively, their wounds don't heal, and would look for von Willebrand's disease. And the oldest woman I ever diagnosed was 90, and it was her first operation, and she gave a very nice history of easy bruising all through her life. And then the other thing that happens is that the big molecules, because you've got a range of molecules normally, the big molecules can be broken down by shear forces, and classically that happens in extracorporeal circuits because you've got a lot of stresses on blood flow. And then if you've got a very tight valve, aortic valve, then it will smash up the von Willebrand factor too. And occasionally people get antibodies to their von Willebrand factor. Von Willebrand factor also controls angiogenesis. So if you haven't got enough von Willebrand factor around, you might get overgrowth of blood vessels, particularly in the gut. And I've written in there Hades syndrome. So that's somebody who's had long-standing absence of the big molecules of von Willebrand factor, and they've developed new vessels in their gut. And then you've heard about coagulation. Now, coagulation is a story that can be told in many different ways. This is the old-fashioned one. We don't believe this anymore. We believe in the cell-based model of hemostasis. But essentially, you don't really need to worry about what's happening all the way through. We've got a cascade system that's amplifying what's going on. We want fibrin out at the bottom, and we want something to activate it. And most of the time, if we look at any situation, it's tissue factor. And we need to remember that tissue factor is not normally in contact with the blood, but if you cut through the endothelium, it's there in the cement underneath the endothelium, and it's in all of the extracellular tissues. So if you do get cut or you do get stabbed, the tissue factor around your organs, around your vessels, will help you form clot. And then we, on the basis of coagulation, have developed anticoagulants. So I've just put in some of them there. Warfarin is a horror, old-fashioned anticoagulant, and it takes out all the vitamin K-dependent proteins. That's factors 2, 7, 9, and 10. It lowers them. And then we've got new drugs called direct oral anticoagulant, and they are the factor 10A inhibitors. So what they effectively do is when factor 10 is activated, they'll bind to the binding site. And then we've got another one called argatroban and dabigatran, and they will do the same to thrombin. So we have the potential within us, because you've got so much fibrinogen and so many platelets, that you could just clot up totally. Just clot all your vessels. There has to be checks on the system, and we've got two major physiological anticoagulant systems. What's so beautiful about them is that this one in particular, it won't work as an anticoagulant until you've got clotting occurring. So it's very clever. As soon as you start forming a clot here, then some of the thrombin that's being generated will leach out, and it will bind to the lining of the blood vessels, the endothelium, and actually switch on this reaction, turning this inert protein C into activated protein C, which will bind to activated factor 8 and factor 10, acting as an anticoagulant. How beautiful is that? And it just shows how phylogenetically old hemostasis is. We've got these amazing, complicated systems. It's even more complicated than that, because it's happening by binding to this molecule here, thromboembolism, which is present on the endothelium. If the endothelium gets activated, so you've got a load of cytokines around, you've got sepsis, you're really unwell, then the endothelium thromboembolism will be pulled in. It'll be endocytosed so that you won't be able to switch on this system so well, so you'll be even more prothrombotic. And then lastly, my favourite physiological anticoagulant, antithrombin, also known as antithrombin 3 by the Americans, but there is no antithrombin 1 or 2. So in Europe, we call it antithrombin, but unfortunately, it's antithrombin 3 in all the American systems we use at the hospital. So this is a small molecule that will bind to activated factor 2 thrombin and activated factor 10. And normally it's circulating and it's slightly closed. And so it can't really bind very well. And what happens when its catalyst sits on top of it here, so which is actually heparin, then it will open up its enzymatic center and it will bind very, very well. So antithrombin is fairly inert, but if it gets in contact with heparin, then it will be very activated. And whilst you're sitting there, what's stopping you from having a deep vein thrombosis is that the endothelium in your deep veins is coated with heparan sulfates, glycosaminoglycans, and they're just grabbing, passing antithrombin molecules to keep your legs anticoagulated. And then lastly, fibrinolysis. Now, fibrinolysis, the term means clot breakdown, but really this is a system that's got many effects. It will break down extracellular cement. And it's important for things like ovulation, letting the egg be released, and metastases of cancer cells. So if you've got some of the molecules that activate fibrinolysis on your cancer, for example, in breast cancer, UPA, which is also urokinase, if that's expressed on your breast cancer, then you are more likely to have metastases because that cell is able to switch on plasminogen locally and wriggle its way out into the bloodstream. And then the other thing about fibrinolysis is phylogenetically it's so much older than hemostasis. So this ability to break things down was present millions of years before hemostasis. It developed separately, and it was, I think, an afterthought that it realized it could break down clot. So we had a discussion earlier about the formation of thrombosis. Here's the classic picture of Virchow, who in 1842 described Virchow's triad. Why do we have venous thrombosis? Well, there have to be changes in the blood flow, there have to be changes in the vessel wall, and changes in the blood. And there's not much else you can say, really. We can go home now, because that is what are the predisposing factors to venous thrombosis. But of course, there's a level of complexity there that we're going to discuss. So let's imagine we're making a deep vein thrombosis. Here we've got a leg vein. Now we have to remember what the difference between veins and arteries is. Arteries have got muscular walls and they will help propel blood forward. Your veins are just big, thin-walled vessels. They can't propel blood on. They're capacitance vessels in that they've got a lot of laxity and they can get a lot bigger than they are probably at the moment. So they are absolutely dependent on the muscles around them squeezing and pushing the blood up the leg. So when I walk along and I move my muscles, not only are my muscles contracting, but they're squeezing the blood up my legs. And the blood doesn't go down the legs because it's got valves intermittently all the way up the whole leg. So if we have a period of stasis, and I'm saying to you, I'm not going to go over 90 minutes, because if I sat you in a chair and you didn't move for 90 minutes and you had your legs crossed, the blood flow in your popliteal vein will fall by 50%. And that's why sitting for long periods sets up DVT. Immobility, out of all of Virchow's triad, is the biggest risk factor for deep vein thrombosis. So when you go next on your long haul flight, please kick your legs around and stand up now and again just to get your legs moving. So this vein here, it's been static for a while, and what happens is because there's poor flow within the valve, this is our modern cant, you've got an area of hypoxia here, and the hypoxia will cause endothelial cell activation. You'll get a bit of p-selectin and other molecules expressed there, and you may even get tissue factor there, and you'll start to get the growth of a clot. And it will just continue to grow because it's very static. And then it will reach out and it will cross over and block the whole vessel. Now that clot is a mixture of fibrin and platelets, a few red cells stuck. But you can see what's happened now is you've actually got a damming back of the blood. So all the blood gets stuck here. And this explains why, if you look at venous clot early on, you've got layers of white and layers of red. They're called lines of Zahn. In arterial clots, there's much better flow, and so the clots tend to be, certainly at the head of them, very white, because it's only the platelets clinging on to the vessel wall that will stay there. But you can get that same phenomenon in arterial clots. If you cause total vessel obstruction, you get the damming back, and the clot will extend backwards. It can also extend forwards. So the problem with venous clotting is, well, a bit of it can break off and travel through the body, through the heart, and block all the blood supply to the pulmonary arteries, and you can die. And then if you have a less big one, you've got a recurrence rate of about 30% at 10 years. And then if you really damage the veins in your leg, so you lose the valves, if you have clot in the leg, you'll lose that valve, which is because it's got hypoxic and caught up in the clot. So when you stand up, all the blood will fall down to your feet, and you'll have very high venous pressures, particularly in this area here, and the skin can break down and cause an ulcer. So venous ulcers are still a major problem in medicine, and a real argument for not having a DVT in the first place. And the other problem is you can continue to have pulmonary emboli, and they will carry on quietly, and you can block up all of your pulmonary arteries with clot, which occurs probably in about 2% of people who are not monitored. So when we talk about risk factors for clot, we are talking about immobility, and then sticky blood, thrombophilia, sticky blood, whichever term you like, and changes in the vessel wall. And these are some of the major ones. I think the first one to say is, as you get older, your blood gets stickier. So increasing age, when you're 20, your blood's quite runny, your fibrinogen levels are low. As you get older, you have to consider aging is a disease of inflammation. Your fibrinogen might be very high, and you'll have lower levels possibly of physiological anticoagulants. Your factor 8, your von Willebrand factor might be much higher. So that if you are immobile for a short period of time, for example, you take yourself off to bed with flu at the age of 80, you can really have a DVT, which wouldn't happen at the age of 20. And then for women, the biggest problem is exogenous estrogen, so the combined oral contraceptive pill or the oral hormone replacement therapy, and of course pregnancy and the postpartum period, because you get this huge prothrombotic state. In the UK, every year, we do postmortems on all the women who die in pregnancy and postpartum. I think in France they do too. And at the moment, blood clots remain the #1 cause of death of women in pregnancy. And the last week we've been having some national meetings to say, what are we going to do? Our system is not good enough at preventing them and diagnosing them. Then we've got cancer. So having cancer, lots of cancer will express tissue factor or tissue factor-like substance on their cancer. And then we've got anybody who's ill. So if you have an inflammatory illness, by which I mean you have pneumonia, or you have Crohn's disease or ulcerative colitis, anything that makes you have inflammation, you put up your chances of having a clot. So I'm going to go on to diagnosis. So when we come to think about clot, we're talking about a rate of 1 per 1,000 of the population, the white population, because the other colours have not been studied so well, will have a clot every year. And when we look at the breakdown, 60% of them will be due to hospital admission, because all of those risk factors I mentioned to you are in the hospital mainly. So about 60% will be hospital-associated venous thromboembolism, and that means they occurred in hospital often 90 days afterwards. So we have lots of algorithms to diagnose clot, and once you're suspecting one, you would do a D-dimer test, which is telling you about fibrinolysis, and which I need to explain later, and also do an ultrasound scan. And for looking at pulmonary embolism, we have these various tools we can use, which have been well validated, and we look at signs and symptoms and come up with a score, and look at the D-dimer as well. So the issue for us in the UK, and I know in France as well, and I know generally, is we know what DVT are, we know what pulmonary emboli are, but we miss a lot of them. When we look at how they break down, we should really pick up, if we're following people properly, about 2/3 will present as a deep vein thrombosis and 1/3 as a pulmonary embolism. And you can remember that picture I showed you of the clot extending. Well, if you start having a clot in the calf, it will extend up into the thigh in a small percentage of patients. If you start in the thigh, your risk of having a pulmonary embolism is much greater. And we still have the problem is we miss people because by the time they've had a pulmonary embolism, they've got a 1 in 10 chance of actually dying within the hour because they've had a great big amount of clot move through the body and block the blood supply to the lung. So in the UK, we have a problem because people think they know what the signs and symptoms of deep vein thrombosis and PE are, but actually, I don't think they do. So here we have some stories. Try to keep you awake. With some real life stories. So this is a woman, she'd had a baby 4 weeks ago, and she'd had a major bleed after she'd had the baby. She'd had a big tear. And when you have a major bleed, she lost more than a litre, it's a risk factor for having a clot later because you're setting off an inflammatory response. And she developed pain in her leg, and the midwife said, oh, that's a muscle sprain. And then she went to see her general practitioner, and they said, no, it can't possibly be a DVT. You haven't got any swelling or redness. And eventually she saw an osteopath who said this is probably a DVT and sent her to the emergency department where she proved to have a DVT. So we have a problem in healthcare with what people recognise as signs and symptoms of DVT. This is another one. This is a 19-year-old who's previously had asthma, so tendency to get breathless at times. She started the combined oral contraceptive pill, and 2 months later she became increasingly short of breath. And she was taken to a local ITU because she was so breathless and treated for asthma, but she was still very short of breath on discharge. And she was readmitted again, but this time considered to have panic attacks and referred to a psychiatrist. Now, if you're having recurrent pulmonary emboli, you're getting hypoxic. And what does hypoxia do? It makes you panic. So she was discharged and she became short of breath again and collapsed at home. And once again was in the emergency department, and the physician had a rethink, thought perhaps I better do a D-dimer test, which is a measure of clot breakdown, which will go up when you have had a DVT or a PE. And so treated her, but now she's lost faith in the medical profession and has post-traumatic stress disorder. And then this last one, this is a 13-year-old boy who had pain in the right iliac fossa in the groin, went to the emergency department. They did all the tests for appendicitis, but he had a normal ultrasound of the abdomen. You'd normally have a look to see if the appendix was inflamed, and a normal white cell count. So he was sent home, and 3 days later he collapsed at school, had no pulse. And the ambulance came, and luckily he survived, but he'd had a massive DVT, which turned into a massive PE. So why am I telling you these stories? Because DVT and PE can happen to anyone, not just in hospital. And we have to ask ourselves, why is the medical community missing VTE? What's in the medical textbooks? Well, if you open the old ones, they have great big pictures of people with massive swollen legs. So everyone thinks massive swollen leg is a DVT. And usually they're expecting a change of colour. And classically for pulmonary embolism, you're meant to be short of breath and have chest pain. And you might cough up blood, but coughing up blood is pretty rare. And then when you go on the internet and you have a look around to see what's going on, you'll see all of these people are meant to have a DVT, and actually some of them have had multiple DVTs. This one here, this is a post-thrombotic leg. You can see a lot of pigmentation and scarring and contraction of the leg. Goodness knows what this one is, but that looks like a cellulitis. So the internet is reinforcing this thing of changing colour. But is this true? So when we look at the different websites like the Mayo Clinic, they will say leg swelling first, and then they'll say leg pain. But the fact you put swelling first means people always expect to have a swollen leg. Here's another one. Diagnosis of DVT can be very difficult. Yes, that's true. Limb pain and tenderness along the limes of the deep veins. No, that's not one. That's a sign of perhaps some superficial thrombophlebitis. Swelling, pitting edema. So all of these sites are reinforcing the fact that your leg has to be swollen for a DVT. This is much better. This one says throbbing pain in the leg, swelling in the leg comes second. And I co-wrote this one, trying to get them to put pain first. And still we've got loads of stuff about swelling. And we have to remember that lots of people will present with a pulmonary embolism without any leg symptoms at all. So if you look at people with pulmonary emboli and who've got no leg symptoms, they account for about a third of them. And when we do post-mortems on people who've died from fatal pulmonary embolism, they may or may not have residual clot in the leg. It depends on whether the whole of the clot's embolized or part of it. And here we've got some clot that's been pulled out of the pulmonary arteries by a cardiac surgeon for somebody who was acutely unwell and would have died without pulling all of this out. And you can see these have come up from the leg, and they're all curled round in the major pulmonary arteries. Are they red or white? They're a mix of colour. And we know that, we know that if you've got a clot in your iliofemoral vein, which is quite high up, you're going to get some pelvic pain. So we can get clots anywhere, right from here, up in the thigh, and then in the iliofemoral area, which could mimic appendicitis. I think this is the crux of symptomatic and asymptomatic DVT, i.e., do they have any major symptoms? And this is a study looking at people who had hip and knee replacement, looking at 5,000 patients and looking to see if they had any clot. So in the hip replacement, 2.7% actually had symptomatics. They had pain and problems, but 13% just had no symptoms at all. For the knee replacement, much less. I want to say that this is a study from 2007, and these days we wouldn't expect such high rates of clots because we mobilise patient after hip and knee replacement very, very quickly, but we didn't then. So we've got lots of cases of iliac vein thrombosis looking like appendicitis, and it's just that the medics just don't seem to know that there's this range of symptoms. Have I got another set of slides now?
This is the end of the part one?
No, there's part two.
Part
yes, sorry, there's part two. So at the moment, I run a charity I started 20 years ago called Thrombosis UK, and we're working, trying to improve understanding of the signs and symptoms of DVT and PE in our healthcare professionals. So that's my first slide, yeah. Okay. I think I've done this. It's not moving on. So just to end this story, in the UK, and I know in France, because I've done some medical legal work for some French cases, patients are coming to see healthcare professionals and they say, I might have a DVT, having Googled the symptoms and signs, and they're being told by a healthcare professional they don't have a DVT because they don't have the classical textbook symptoms. And in the UK, we have a medical legal service which supports our National Health Service. And at the moment, there are quite a number of cases where people have had missed DVT or they weren't given the right treatment, and it's costing the NHS about £10 million, which is 12 million euros over 5 years because they're getting compensation. So coming back to the global picture of VTE, we said that it's about 1 in 1,000 individuals will get it annually. It's estimated that it causes more than 500,000 deaths in Europe every year. We're not sure about the other countries. I suspect that there's quite an underestimate. And there are now organizations such as World Thrombosis Day, which are trying to increase awareness in the public about the signs and symptoms of DVT and PE. Now I'm going to go on to sticky blood, thrombophilia, because we've got those three Virchow's triad. I sort of feel that many people here are looking at flow. Some of us are looking at what changes in the vessel wall, but out there in thrombosis practice, a lot of us are looking to try and identify thrombophilia, changes in the blood that predispose you to having venous thromboembolism. And just to remind you how different arterial and venous disease is. So if you think about what are the risk factors for arterial disease, we're talking about atherosclerosis, we're talking about hypertension, smoking, lipids, obesity, probably, diabetes. Very different from what I'm going to tell you about here. So we've got two definitions. I'm sure there's a French one too. So it's individuals who appear to have a predisposition to develop venous thromboembolism. And this really all comes from work over the last 20, 25, 30 years. Various risk factors have been found. And everyone got very excited when we first noticed that people could have antithrombin deficiency or factor V Leiden. Factor V Leiden was discovered in the 80s and 90s. So we all thought, oh, this is going to solve everything. We're going to find out why everyone is having clots. And then we realized, actually, no, most people who have clots don't always have something like this. So they entered a phase where nobody wanted to do thrombophilia testing, and we're really coming out of it again at the moment. That's the natural curve of any test. Everyone thinks it's the best thing that's ever invented, and then they get disillusioned. And one of the problems with thrombophilia testing, to look for these inherited predispositions to venous thromboembolism globally, is that they're used inappropriately. So people use them after stroke and heart attack. They don't increase those risks. And then we have the ongoing problem that if we have somebody who's got venous thromboembolism and a strong family history, so mum's had something, sisters had something, they've had something, we will only find an inherited defect in about 50% of them. So we don't know enough about coagulation in 2024. And then we've identified some really low risk factors such as factor V Leiden, which increases your background risk of having a DVT eightfold, and there's something called prothrombin 2210, and that doubles it. They'll never have a clot, probably. Most of them will die without having had one, but you are generating a generation of worried well. And then when we look at the testing, it's only looked at the white population. If you're African or Asian, you haven't really been studied properly, so we don't know what other problems are out there. And when we talk about factor V Leiden, which is a defect in factor V that makes it resistant to protein C, it was first seen probably hundreds of thousands of years ago in Turkey and spread out across Europe. Prothrombin 2210, similarly from southern Europe, some probably from around here too, and they have spread out across Europe. So what do we actually do if we think someone has got an inherited tendency to venous thromboembolism? Well, we can offer them this range of tests, and we would measure antithrombin levels, protein C levels, protein S levels. We do the test, activated protein C resistance, which is the functional test to find the genetic answer factor 5 Leiden. Prothrombin 2210, which is also sometimes known as prothrombin Leiden, that doubles the levels of prothrombin because there's a defect in the promoter area of the prothrombin gene, and then low levels of fibrinogen. And we know that if you're blood group A or B, you've got a higher risk of venous thrombosis as well. And we have some acquired defects too. Well, what has been happening over the years is this crazy thing called MTHFR has been measured. It had lots of little studies. It's a defect in your ability to metabolize homocysteine, and we are saying, please stop doing this test. You're labeling people, and there's really nothing wrong with them. So this is a call to arms to say, please stop doing this. And then we've got the problem that the thrombophilias are different. So we've got high-risk thrombophilias, and most of them are quite rare, about 1 in 5,000 of the population. If you have antithrombin deficiency, you've got about a 50% risk of venous thromboembolism before you're 50, and you've got a 50% chance of having a clot in pregnancy without prevention. Whereas you've got these low-risk ones, which on their own have very little effect, but if they're combined with something else, will increase the risk. So antithrombin is on chromosome 6, factor 5 is on chromosome 6. They're quite close together, so 25% of those with antithrombin deficiency will have factor 5 Leiden as well, and then it really counts. So this is looking at the prevalence and the relative risk, quite an old slide, but you can see here antithrombin really increases your risk of venous thromboembolism, but thankfully it's pretty rare. And then we have antiphospholipid antibodies. These are autoantibodies, and they will cause thrombosis anywhere in the body. So they don't just cause venous thrombosis, they will cause arterial thrombosis as well, straight thrombosis in normal vessels, unlike atherosclerosis, and they can cause pregnancy loss in the first part of pregnancy, and also late loss. They cause thrombosis in the placenta later on, and they inhibit the early cells from growing in the first trimester. So we do have a much more permissive approach to antiphospholipid antibody testing. Really, anybody who's got unexplained clotting or unexplained problems in pregnancy that fit the bill, we would do the testing. And certainly for young people who have a stroke, about 40% of them will have antiphospholipid antibodies. Horrible testing to do because the tests have bad names. So one of the tests is a lupus anticoagulant, not a test for lupus, not a test for anticoagulant, a double misnomer. And then we have to measure anti-cardlipin antibodies and anti-beta-2 glycoprotein 1 antibodies. We must do all 3 tests because some of them will only be positive with one, and these antibodies can interfere with some of the other assays. Oh. I seem to have lost a slide. Never mind. Oh, I know it was. So when do we test people? When they're hemostatically stable, so not just at the time of a clot, because they will have low levels perhaps of the physiological anticoagulants. And then the person who tests needs to understand them as well. Now, one of the problems with the testing is we don't have any international consensus on when to do them. So this is an international survey that I did with Martin Ellis, who's a physician in Israel, a couple of years ago. So we sent out a survey of questions asking them what did they do. They're all physicians. They're all experts in thrombosis and hemostasis, and they're all consultants. And we asked them what they practiced and where they practiced, and you can see we've got a spread from all over the world. And then we asked them questions about when would you use thrombophilia testing. And we gave them an example. This is a 76-year-old woman who's had a deep vein thrombosis after hip surgery. Now, we nowadays divide deep vein thrombosis and PE up into provoked and unprovoked. And this is a classic provoked event. She's had surgery. She probably had blood thinners, but we still see clots afterwards. So her chances of having another clot are very low, and so we would usually give her 3 months anticoagulation and stop it and say, that's it. If you have any future surgery, yes, you'll need blood thinners, but you don't need to have long-term anticoagulation. So we all agree we probably wouldn't perform any thrombophilia testing in this lady because it's not going to change anything. And then this one is very different. This is the other extreme. This is a 41-year-old man who's healthy. He's got no family history of thrombosis, who has had an unprovoked proximal deep vein thrombosis. So this is unprovoked. And this is very different. We now have wonderful blood thinners, low risk of bleeding. They're tablets. They don't need monitoring. He might go on something like rivaroxaban and stay on it indefinitely because his risk of recurrence, because he just came out the blue, was unprovoked, is at least 30–40% over the next 10 years. And the question is whether you do thrombophilia testing, and there's no agreement. You can see some people would not do any, some people would do a bit, or just do antiphospholipid antibodies. Here we've got another provoked event, a 34-year-old woman. She's been put on the combined oral contraceptive pill, and she's been taking it for 5 years, and she has an event. This is a little bit more blurred. If you put someone on the pill, you'd expect to see if they're going to get a clot within the first 18 months. So this is a little bit later out. So there's no agreement how we would manage them internationally. And you can see there's no agreement at all about whether you do any antiphospholipid testing or an inherited thrombophilia test. Some might do it because it might push them over if they found something, to putting them on long-term anticoagulation. Others might say, well, you're on the pill, we can stop the pill, take it away, your blood will be less sticky, and you won't need a long-term blood thinner. So just to summarize thrombophilia testing, just to give you a flavor of it, it's a little bit of a limited value. It's widely used inappropriately. We don't all agree when to use it. We're just about to write some international guidance at the moment for the International Society of Thrombosis and Hemostasis. We need to educate people about how to use them. The other thing I haven't even covered is that some of the tests aren't always well performed. And we really need nowadays not just to measure something in the blood, but to do the genetic analysis. And we need more research to identify the other inherited thrombophilias that clearly exist. Right, I'm going to stop now. Does anyone have any questions?
Thank you very much for this very nice presentation, of course. Any question from the audience? Yes, yeah, sorry.
Thank you for the great overview. I have a couple of questions, and of course they're flow related. So I'm curious about how the collateral veins, the collaterals start forming after occlusion, because in some of the work I've done, it seems like they form rather quickly. And so does that, how much of a role does that play in sort of the diagnostic timing?
So when you make a diagnosis of a clot, you're doing imaging and you're looking for clots either in the deep veins or in the lungs with a CT pulmonary angiogram. The collaterals can come up very quickly, and certainly you can see them in intra-abdominal clots or not conventional DVT and PE. If you've got a high iliofemoral clot, you quite often see the collateral vessels come up within 6 months. But the problem is you haven't got a valvular system in the collateral veins, so they do tend to get bigger and bigger. So every individual is different as to how much of the collateral veins comes up. What are you going to ask me next?
So the other question is, and we've sort of talked about this in the past, but sort of related to pregnancy, but also related to May-Thurner syndrome and the influence of anatomical structures and changes influencing DVT.
So in pregnancy, you are going to have May-Thurner's probably exerting a greater force. Does everyone know what May-Thurner's is? Okay, so when you look at the top of the iliac vein on the left, it's crossed by the iliac artery, and sometimes there's quite a lot of pressure on that vein and it obstructs flow. And we call it May-Thurner syndrome. And in the States, a lot of people stent people who have a DVT if they find any evidence of May-Thurner syndrome. We're not clear, though, whether it makes much difference. If you think about pregnancy, so you've got more pressure on the veins, the general rule in pregnancy is that 70% of all clots are on the left and they're iliofemoral. Now, to me, that means that May-Thurner's is really quite important in pregnancy, especially with the pressure of the gravid uterus. And the other issue in pregnancy is that when we look for risk factors for having a clot, and we go through all the thrombophilia tests, and we see, are they obese, do they smoke, blah, 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 blah. About a third of them don't have anything there, and it would suggest that they probably have flow problems. And flow in pregnancy really needs studying. I think I've said this to you before, haven't I? And in the UK, we do have this crisis that somehow we use huge amounts of blood thinners in our women, but we've still got huge rates of venous thromboembolism. Now, we do have the obesity pandemic. Our average BMI in the UK is hitting 28. It's not the same as in France or the rest of mainland Europe, very much similar to the States. We're following that. So that's one of the factors. But I think the whole issue of flow through the leg veins in pregnancy needs looking at. Thank you, Keith. Are you going to offer to do it?
I'm working on it.
Good. There's going to be funding calls in the UK. I'm just telling you.
A curiosity question, maybe just a wide question about VT. So, with my former PhD student, we're thinking, do we know if VT exists in other mammals than humans? And in hibernating animals that don't move for a very long time, are they signs of VTEs? And what protects them if not? Is it known?
Have you looked at all the recent work?
No. So curiosity.
Okay, so they have been looking at hibernating animals And there's a big review of it in one of the journals of thrombosis and hemostasis last year, which throws even more light on it, by Nigel Mackman. Basically, there was a study that showed that in hibernating brown bears, they have changes in blood constituents, and one of them is an increase in heat shock protein. And they tried to implicate heat shock protein as perhaps being anti-thrombotic. But then they've looked at squirrels, who hibernate as well, and other types of bears. And some of them have a change of hemostasis in that their blood definitely gets more runny. So there's something going on in those big mammals that hibernate, which means that they don't have a high rate of venous thromboembolism. But it's different between species, and I'm not sure how well you can implicate heat shock protein from the data. It just went up. Well, but it was just they happened to look at it. And it could be something else that's driving it all.
Thank you.
As a follow-up, do they have also valves, those animals, hibernating?
Valves in their legs?
Yeah.
Yes. I don't know, or I haven't ever dissected one, have you? Oh, we have to ask a vet, don't we?
I will guess squirrels no, but giraffes oui, but they don't hibernate.
Yes, I suspect they will, won't they?
Well, the mice have.
Mice do.
Well, mice have they have like one or two, so they're very few. I don't know. Pierre, have you ever done this? Yeah, well, there's this nice JCI study from Mark Kahn looking at the endothelial cell phenotype inside of the venous valves, and it's in a mouse. I think there are very few, like one or two.
And,
they don't have a lot of
what
pressure.
did they find of because endothelium is so heterogeneous? What did they find in the valve?
I think a lot of what you
endothelium?
would expect: upregulation of thromboembolism,
Yes.
upregulation of
How clever.
fibrinolysis. So
How clever.
Yeah, so it's a
Well,
pretty neat
it's
study.
evolution, isn't it? It's picked
Yeah.
those out.
But
yes.
it's a very one side of the sinus has a very different endothelial cell phenotype than the other side of or the other side of the valve, I should say, of the so.
Amazing.
Yeah, quite interesting. Since I have the microphone, I'm going to ask a question. Why mice?
Is so small. The pressure difference is so small.
Why do they have a valve? Yeah, I don't know.
Wow.
I was curious. I wonder if you could speak a little bit about normal variations in protein C and protein S, so not necessarily significant genetic deficiencies, but just maybe acquired or in the normal variation, and how that does it correlate with VTE? Is that worth measuring? Not to put another useless test out there, but I'm just sort of curious about your thoughts.
So you can have a deficiency of protein C, and it can be either amount or it can be function. Obviously, it depends where the polymorphism is, either in the promoter area of the gene or within the gene. Its prevalence is about 1 in 5,000. We have to remember it is an inactive precursor. So it's much more interesting to think about thromboembolism, because you need thromboembolism to activate it, don't you? And if you're septic, part of endothelial cell activation is the pinocytosis of thromboembolism into the endothelium. If you have disseminated intravascular coagulation, so everything's just in a storm, you'll have low levels of protein C. You'll have low levels of protein C after you've had a big clot, because it's trying to counteract the clot. That's about it, I think. Low levels of protein C on warfarin, because it's a vitamin K dependent physiological anticoagulant.
Data show that the incidence and prevalence of VTE seems to be higher in patients, sorry for the term, of low social class.
Yes.
Would you comment that in terms of prevention and so on?
So the issue really is the other things that happen with low socioeconomic class. So in the UK, our low socioeconomic class are more obese. They have very poor diets. They smoke more. So they have maybe more risk factors for VTE, and then maybe they're not so well educated to know what they're looking for, and they have less social capital. In that, I mean, they go to the health service and someone says, well, you haven't got DVT, and they just go away, whereas a middle-class person will say, no, I really think I have one. I've read about it. And so they'll push their way through. So many, many reasons, I think.
Sylvie Bouvier, Nîmes University Hospital. Thank you for your talk. I have just one question. What do you think about non-conventional antiphospholipid antibodies?
Unconventional ones, you mean?
For example, anti-PSPT?
Yes.
What do you think? Do you search for them?
So the issue is that they do occur, yes, but they're not really very helpful in the diagnosis of antiphospholipid syndrome. And we've measured them in research studies, but they haven't added very much. So I think we have to keep looking for antiphospholipid antibodies, because it's still not clear what we're actually looking for. We have to do 3 tests, and one of them has to be positive. Well, this isn't quite right. Is it that the antigen that they're all acting against is different, or what is going on? So there's too much unknown about antiphospholipid syndrome, but I wouldn't recommend unconventional testing for diagnosis, but as a supplementary test. Is that what you're doing?
Okay, thank you.
Thank you.
Any other question? Yes.
Curious about chemotherapy and the CVCs, the central venous catheters. We've been looking at this, and it's not entirely clear whether it's flow dominated or chemo dominated.
So there's a lot of data on central venous catheters, and the data would suggest that it's all flow dominated, and that putting someone on an anticoagulant doesn't make any difference. So that's clearly because the anticoagulant's not getting into the catheter. So I think that's a problem. There are some chemotherapeutic agents that are prothrombotic. So some of the drugs used in myeloma, such as thalidomide, have increased rates of venous thromboembolism associated with them. But the linkage between what you're putting down your central venous catheter and the rates of thrombosis, I haven't noticed there's any difference. We've got 2 problems. We've got a central venous catheter that might be obstructing the vein, and then we've got a drug that might increase the rate of VTE. Are you going to tell me I'm wrong? I'd like to know that I'm wrong.
No, I think it is flow dominated.
Yep.
It's also the indwelling catheters.
Yes.
Right. Those are the ones that are higher risk.
Yes.
But it seems to be positioning of them.
Yep. And very common in children, and you can imagine they're more common in children because they have smaller vessels and they haven't put the size of the catheters down to tiny little. They're still quite significant, so they will cause quite a lot of flow-related problems. I think this should be the last question. You should all have wine.
Wine is not ready.
No?
So I can take my time, okay. For me it was really interesting or shocking to see how many people are not being diagnosed. because they don't have like this textbook perfect symptoms. And I would like to know what's what's your opinion? What is the reason for that? Is it also caused by like the fact that basic research is also often done in less diverse cohort, and so you don't have like this this big list of symptoms that could be narrowed down? So, or are there other factors that play a role in this misdiagnosing? Or
so the problem is that the finding that most DVT don't cause any symptoms or just cause pain is new, and all the old textbooks are still around, and when people lecture to the medical students they tend to repeat the old lectures, and so the new findings aren't being taught in medical school. We have, with my charity, we've approached all our medical schools. They have a committee, and we said, please, can you educate people better about venous thromboembolism? And their reply is, no. We are sending medical students to universities to learn how to think. There shouldn't be any part of the syllabus where it's prescriptive. So we have to, in the UK, especially with women, because of our high rate of venous thromboembolism in pregnancy, we are going to have to educate our public more, and at the start of pregnancy, or even before then, we have to educate them, and the men as well, about their risk. Because actually men have a high risk of clots throughout the whole of their life. Women's risk is greater during the fertile years, but overall more men die of clots than women.
And also, if I can, that's the last comment, if I can dare to comment, one destabilizing point is that if you compare expert recommendations, for instance, in the prevention of DVT during the postpartum period, you can have, depending on the recommendation, from 5% to 80% of the same patients that would have a prevention. So there is so much discrepancies between expert consensus that it's very hard for
practitioners. Now you're really going to make my blood pressure rise, because the whole problem around pregnancy is that there's no R&D, there's no research around pregnancy, and that's really goes back years because of the misogynism in research and development. The average research committee used to be full of men, and it's changed very fast. But the ethics committees are reluctant to do studies in pregnant women because they think of the baby and look after the baby. And then in the States, a pregnant woman until 20 years ago was not thought to have capacity. So they were in the same status as prisoners. They didn't have the right to say, no, I want this or I want that. So it's all very difficult. And then there are inherent problems of doing studies in pregnancy, because the pregnant woman is saying, you can do anything you like, but you can't do anything that will harm my baby, which is the right way to do it. And luckily, the blood thinners we use are not harming the baby, but they're injections, and they don't like injections. So it's all very poor. So in the UK, we're just starting up. We're going to have to start up a lot of studies. So we're doing a study. We're looking at learning about pulmonary embolism in pregnancy, and we're going to do some trials in thromboprophylaxis. And the really big area that no one has looked at is abortion. So in the UK, we have 600,000 pregnancies every year. How many abortions do you think there are? 200,000. I mean, this is huge numbers, and then, and then we have deaths around them, and there's no assessment, no prevention, no data on what's happening to their blood around the time. So we're going to have to look at all of those things. Well, you can too, can't you?
With great pleasure.
Yes, that would be great.
So no more question? So thank you very much, Professor.
Thank you.
Thank you.